You know, I was in a coffee shop the other day and I was watching this barista make a latte. And she was just so focused on the foam, the angle of the pour, just, total precision. And it got me thinking how much we appreciate that kind of precision in things we can actually see, like architecture or watchmaking. But we almost never think about the architecture inside our own bodies.
Yeah, and that's probably a good thing, right? If you think about your internal architecture, it usually means something hurts.
Exactly. But today, we're going to make everyone think about it because we are diving into a stack of documents that are, well, they're essentially the blueprints for the most high-stakes, microscopic construction site in the human body.
We're talking about the ear.
We are, but not the sort of wash behind your ears version. We've got our hands on a set of high-level revision notes for otology.
Yeah, this is the heavy-duty stuff.
It's what surgeons review before they start drilling into your skull. And honestly, it reads less like biology and more like a manual for defusing a bomb. In the dark.
That is a surprisingly accurate description. I mean, when you look at otology, you're dealing with a space, the middle ear, that is roughly the size of a sugar cube. Maybe 1 milliliter of volume.
1 milliliter, that's it.
That's it. And inside that 1 milliliter, you've got the smallest bones in the body, a nerve that controls your smile, a sensor that tells you which way is up.
And a direct window to the brain.
And the margin for error is, well, it's basically zero.
So our mission today is to decode this cheat sheet. We're going to look at the detective tools doctors use, which involves some really cool physics, and then we're going to map out the danger zones, because apparently there are places inside your head with names like the cog and Troutman's triangle that are legitimate hazards.
It's a fascinating mix. It really is part acoustics, part structural engineering, and part high-stakes navigation.
Okay, let's start with the detective work. I was honestly shocked that in an age of MRIs and CT scans, these notes start with a piece of metal invented in 1711, the tuning fork.
It's a classic, invented by John Shore, who was a trumpet player for the Queen, actually. But in medicine, we're not just making noise, we're testing physics.
And the notes are super specific here. They say for general testing, you can't just grab any old fork. You need a 512 hertz fork. They call it the Goldilocks frequency. Why is that? Why not say 224 hertz?
It's all about how sound behaves in the real world. If you use a really high frequency, like 1024 or 2048 hertz, the tone decays. It just fades away too quickly.
Okay.
You strike the fork, you move it to the patient's ear, and by the time you ask, can you hear this? The sound is already gone. It's just not reliable.
So high pitch dies out too fast. What about the low ones? The notes mention a 256 hertz fork.
Well, if you go that low, you run into a different problem, a sensory problem. Low frequencies create a lot of physical vibration. If I put a 256 hertz fork on your ankle bone, you'd feel it buzzing. So if I put it on the bone behind your ear to test your hearing, you might say, yes, I hear it. But what you're actually doing is feeling your skull shake.
Ah, so you're testing the wrong sense.
Exactly. We want to test the auditory nerve, not your tactile sensation. So 512 hertz is the sweet spot. It lasts long enough to test, but it doesn't just rattle your bones.
Except the notes do throw a curveball. They say there is one test where you actually want that skull rattling vibration. The Weber test.
Yes, the Weber. For that test, we put the fork right in the middle of your forehead. We want to see if the sound travels through the bone to one ear more than the other.
So you need that vibration.
For that, the rumble of the 256 hertz fork is an advantage. You want that bone conduction.
It's those little nuances, isn't it? Using the physics of the tool to get the answer. But speaking of answers, there's a trap mentioned in here that sounds like a logic puzzle, the false negative RIN.
This is the bane of medical students everywhere.
Okay, walk us through this. The RIN test compares hearing in the air to hearing through the bone. Normally, if you can't hear it in the air, but you can on the bone, you've got a blockage, like wax, right?
Correct. That's a standard conductive loss.
Yeah.
But okay, here's the scenario. Imagine a patient has a dead ear. The left ear is totally gone. The nerve is dead. Nothing.
Okay, complete silence in one ear.
So you put the tuning fork on the bone behind that dead left ear.
Yeah.
Logically, the patient should hear nothing.
Right, because the ear's not working.
But bone is a fantastic conductor of sound. The vibration travels straight through the skull, crosses the midline, and gets picked up by the right ear, the healthy one.
Oh, wow. So the patient says, yep, I hear it.
Exactly. They say, I hear it loud and clear. But they don't realize they're hearing it on the wrong side. The doctor, if they're not careful, writes down bone conduction normal on the left.
But it's a lie.
It's a total lie.
Yeah.
The good ear is eavesdropping on the test. That is a false negative RIN.
That is wild. It's like the body is actively gaslighting the doctor.
It basically is. That's why you have to mask the good ear. You play static noise into it so it can't cheat.
So the ears can trick you.
Wow.
But reading on, it seems the eyes are just as involved. There's a huge section here on nystagmus.
This is one of my favorite connections in all of physiology. Your inner ear, the labyrinth, it isn't just for hearing, it's your gyroscope.
Right, for balance.
It tells you where your head is in space. If that system gets confused or stimulated, your eyes will try to compensate. They jerk.
The notes define it as involuntary rotatory oscillatory movements, which sounds awful.
It's the room spinning, basically.
Yeah.
But for a doctor, the direction of that spin is a map. The notes mention Ewald's law.
Yeah, what is that?
Ewald's law. It basically just says the eyes will move in the same plane as the semicircular canal that's being stimulated. You have 3 canals, right? Horizontal, posterior, and superior.
So if the horizontal canal has a problem,
The eyes jerk horizontally. If it's the posterior canal, they might jerk vertically or even twist a little. It's literally a dashboard warning light telling you exactly which part of the engine is busted.
and doctors can trigger this on purpose. I'm seeing something here called the fistula test.
Yes. This is a stress test for the ear. You use a little device called a Siegel's speculum, which is basically a magnifying glass with an air puffer attached.
Or you can just press on the little flap of the ear, the tragus.
In a pinch, yeah. You're pumping air into the canal. Now, in a normal person, nothing happens. The bone completely protects the inner ear. But if you have a fistula, a little hole in that bone, that pressure shoots straight through, it hits the fluids of the inner ear, and boom.
The eyes go crazy.
The patient gets vertigo, and the eyes jerk. That's a positive test.
But again, and I'm sensing a theme here, the notes warn about being tricked, the false positive. The test causes dizziness, but there is no hole.
This is Hennebert's sign. And it's fascinating because it's usually caused by structural looseness. One cause listed is congenital syphilis.
I saw that. How on earth does syphilis make your eyes jerk when you press on your ear?
Because in those cases, the disease affects the stapes. That's the little stirrup bone. It becomes hypermobile. It's too loose. So when you press on the eardrum, you're not pushing air through a hole. You're physically shoving the stirrup bone too far into the inner ear.
You're piston pumping the bone because the joint is all sloppy.
Exactly. Same symptom, totally different mechanical failure.
You really have to be a detective. You can't just look at the sign. You have to know the machinery behind it.
Context is everything in otology.
Okay, let's move to the stuff that goes wrong. The pathology. The notes spend a lot of time classifying holes in the eardrum. I thought a hole was a hole, but apparently where the hole is matters a lot.
Oh, location is everything. The notes make a big distinction between a central perforation and a marginal one.
A central one is a hole in the drum, but it's surrounded by normal eardrum, like a donut.
Right. And those are generally safer. They can heal, they can be patched. But a marginal perforation that involves the rim, it destroys the bony groove where the drum actually attaches.
Why is that one so much worse?
Because skin is aggressive. The skin in your ear canal is always migrating outward, cleaning itself. If that rim is gone, the canal skin sees an open door. It starts to grow into the middle ear space.
In skin where it shouldn't be is bad.
It's a disaster. It forms a cyst called a cholesteatoma.
Which brings us to this idea of the retraction pocket. This was a concept I found really unsettling. It's not a hole, right?
No, not yet. It's an invagination. Think of vacuum packing something. If the pressure inside your middle ear drops, maybe your eustachian tube is blocked, the eardrum gets sucked inward, it forms a little pocket.
And the notes say the danger is the potential to retain debris.
That's the polite medical way of saying it fills with dead skin cells that can't get out. That pocket gets deeper and deeper, filling with rotting skin until it starts eating away at the bone.
And there's a very practical field test in here for telling the difference between that dangerous skin cyst and just, well, fungus.
Yes. The suck test.
It sounds incredibly crude.
It is, but it works. So you look in the ear and see this nasty clump of white debris. You don't know what it is. You take your suction tool and you try to clean it. If it sucks up easily,
It's just fungus.
it's fungus or wax. It's sitting on the surface. But if you pull and it stays stuck, or it feels like it's attached to something coming out of the wall, that's a cholesteatoma.
It's not just debris, it's a structure.
It's a bag of skin growing out of the bone.
Yeah.
You can't vacuum it away. You have to surgically remove it.
That is a visceral image, but it sets us up perfectly for the most intense part of these notes, the surgery. We see the middle ear is tiny.
1 milliliter. And it's not an empty room. It's full of drapes and folds.
Yeah.
The notes list the malleolar folds, the incutal folds. These are just mucous membranes that divide that tiny space into even tinier compartments.
And one of those compartments is Prusak's space. The notes highlight this as being crucial. Why?
Prusak's space is this tiny recess, just medial to the very top part of the eardrum. It's important because it's usually ground zero. When that vacuum effect starts, Prusak's space is the first place the eardrum gets sucked into.
So it's the first sign of trouble.
If a doctor sees a pocket forming there, they know the whole process has begun. It's the canary in the coal mine.
Okay, let's talk about the danger zones. These are the places that basically have danger written in flashing red lights. The first one is the sinus tympani.
The sinus tympani is notorious. It's a deep recess, kind of a little cave, that's tucked behind the windows of the inner ear.
Why is it such a problem?
Because of the viewing angle. It is medial to the facial nerve.
Wait, medial means...
Towards the middle of the head. So the nerve is literally standing in front of it. You cannot look directly into the sinus tympani without risking damage to the nerve.
So you could clean out the whole ear, think you're done, but there's still disease hiding in that little cave.
Yes. The notes call it a site for occult, or a hidden cholesteatoma. You think you've cured the patient, but a microscopic seed is left behind in the sinus tympani, just waiting to grow back.
That's disturbing. Okay, so the next one sounds even more mechanical. The cog.
The cog. It sounds like part of a clock, doesn't it?
It's described as a bony ridge hanging from the roof of the ear, and its main job in the notes is just to be a landmark.
A critical landmark. The facial nerve, the nerve that lets you smile, blink, move your lips, lies just in front of and below the cog.
So if you're drilling away bone to clean out disease,
You have to drill the cog away to see what's behind it, specifically a space called the supratubal recess. But if you drill 1 millimeter too far, or if your hand slips, you hit the nerve
and the patient wakes up with facial paralysis.
instantly. And the notes mention that the supratubal recess, that space behind the cog, is particularly dangerous because the nerve there sometimes has no bone covering it at all.
It's just naked.
It's dehiscent, just the nerve sheath, no bony armor. So a spinning diamond drill burr touching that, it's catastrophic.
It feels like this entire field of surgery is built around do not hit the facial nerve.
It completely dominates the anatomy. You see all these terms in the notes like the facial recess, the facial ridge, the facial bridge.
And those are all different things.
Completely different structures. The facial ridge is the bone over the vertical part of the nerve. The facial bridge is a bony strut that covers the connection between the little ear bones.
So if you confuse bridge and ridge in a conversation,
It's embarrassing. If you confuse them in the operating room, you're lost. You're drilling in the wrong spot.
there's one last danger zone I want to touch on because the name is so dramatic. Troutman's triangle.
This is further back in the skull. It's a triangular space that's bounded by the sigmoid sinus, which is a massive vein that drains the brain, and the superior petrosal sinus.
What's the risk there?
If an infection breaks through the bone in Troutman's triangle, it's not just an ear problem anymore. It's heading straight for the posterior cranial fossa. You're looking at an epidural abscess.
Puts pressing on the lining of the brain.
Exactly. So the surgeon is clearing disease from this triangle, knowing that millimeters away is a major vein and the brain's protective layer.
To navigate this minefield, the notes talk about these imaginary lines. Donaldson's line, for instance. This sounds like something off a pirate's treasure map.
In a way, it is. When you look through a microscope at a field of white bone, it all looks the same. There are no street signs, so you have to draw them in your mind. Donaldson's line is an imaginary line. You extend backward from the horizontal semicircular canal.
And where does X mark the spot?
It marks the location of the endolymphatic sac.
Which is?
It's a fluid reservoir for the inner ear. If you're doing surgery for Meniere's disease to relieve pressure, that sac is your target. But you can't see it. It's inside the bone.
So you use the line to know where to drill?
You use Donaldson's line to know where to drill. If you're too high or too low, you miss it. Or worse, you hit something else.
It really is like blueprints for an architectural project. You've got the solid angle, the notch of riveness, all these geometric concepts, just to keep you oriented in a space the size of a thimble.
It really paints a picture of a discipline that demands this synthesis of skills. I think that's what makes otology so unique.
How so?
Well, think about what we've covered, right? You can't just be good with your hands.
Right. You have to understand the acoustics.
Exactly. You have to be a physicist to interpret the 512 hertz tuning fork decay. You have to be a neurologist to understand why the eyes are jerking left and not right. And then, yes, you have to be a master architect to drill down the cog without hitting a naked nerve.
It's the ultimate multidisciplinary challenge. And for us, the listeners who hopefully never have to worry about Troutman's triangle, what's the big takeaway here?
For me, it's a reminder of fragility.
And balance.
Balance.
I keep coming back to that retraction pocket.
The vacuum packing thing. Yeah. It's such a small thing. A little bit of negative pressure. Maybe you have a cold, your ear feels stuffed. The eardrum gets sucked in just a millimeter into Prusak's space.
It's not an infection yet.
It's not an infection yet. It's not a hole yet. But the geometry has changed.
That's not.
That's enough. The self-cleaning mechanism of the ear fails because the shape is wrong. Debris gets trapped. And that tiny, tiny shift in architecture starts the domino effect that leads to bone destruction and major surgery.
It all comes down to pressure and geometry.
Physics meets biology in a very, very small room.
Well, I think I'm going to be a lot more careful about popping my ears on my next flight.
Probably a good idea. Keep those eustachian tubes working.
Thanks for decoding this cheat sheet with us. It's wild what you can find in a stack of revision notes.
My pleasure.
And to everyone listening, keep your ears open and safe, and we'll catch you on the next deep dive.